a really basic definition of what a process evaluation is, which is no easy feat. So mainly we're going to be defining by example. So we've got two examples for you of process evaluations, and they've got really different methods and objectives. The first is a process evaluation that I did of point of care tests for sexually transmitted infections as they were implemented into NHS services in England. And then Abdul will present his work on the fidelity of a nursing care intervention in Kenyan neonatal care units, which he's doing as part of his DPhil. So first, what is a process evaluation? This is something that Abdul and I kind of struggled with because it can mean a lot of things to a lot of different people, and it really largely depends on what your objectives are. So broadly, it's an evaluation that uses a model or a framework to follow the process of how an intervention was or is being delivered using qualitative and or quantitative methods. So why do this? Well, there's a little bit more agreement on that. And so the US Centers for Disease Control says that process implementation evaluation determines whether program activities have been implemented as intended. And the London School of Hygiene and Tropical Medicine says that evaluations should provide information on the planning, delivery, and uptake of the intervention, the causal pathways through which the intervention is expected to act, and the contextual factors affecting the implementation and outcomes of the intervention, aka the process that takes place. So in traditional outcome research, you have an intervention and then an outcome, and there's largely a black box in between. And the recommendation, especially for complex intervention research, is to unpack that black box to be able to look at the processes by which the intervention leads to the outcomes of interest or not. So although there are many different methods in that this can be done by, I'm putting up here a slide from the MRC framework on process evaluations of complex interventions because the broad categories here are largely agreed upon by many different methods of process evaluations. And that's that you should be able to examine the context of the intervention, so that includes the contextual ways that shape how the implementation works. So that would be something like your background of why the intervention is happening in the first place. And then describe the intervention and its causal assumptions. Some people call this the theory of change and understanding how cause and effect are meant to happen within your intervention. And then describing the implementation process, so how the delivery was addressed or achieved. That includes fidelity or adherence to the original plan of the intervention, like how well did the intervention adhere to the plan, how much or what the dose of the intervention was in each of the settings or sites, at the adaptations of the intervention, and the reach. So how many people actually did the intervention reach? Um, and then unpacking that further on mechanisms of impact. So how did what happened actually achieve your outcomes of interest? So I'm going to go ahead and uh, present my STI point of care test implementation study using those broad categories. So for context, we know that in England, chlamydia and gonorrhea are responsible for almost 50% and 15% of all new STI diagnoses, respectively, and that chlamydia and gonorrhea are routinely tested for in the UK in labs using a combined dual detection test, so a very highly accurate nucleic acid amplification test. And the sample to result turnaround time, that's for when the sample gets put into the test device itself to when the result comes to the patient, range from about a day to a few weeks. So there are new tests that are point of care tests that can be delivered in much faster time. And two of these are shown here. That's the Binks combined chlamydia gonorrhea test and the Cepheid combined chlamydia gonorrhea test. And the Binks test has a sample to result turnaround time of about 30 minutes. And there's been quite a lot of research that's shown that actually these tests are highly accurate and comparable in accuracy to laboratory-based tests, as well as cost-effective and acceptable to patients and clinical providers in some settings. Yet many of these tests are not implemented into routine care. So, as part of a study that was co-developed by my colleagues at St. George's University of London, Aquarius Population Health, which is a health economics group, and Binks Health, who are the producers of the actual test itself, we applied for and got funding from Innovate UK to in part implement the test, their chlamydia gonorrhea tests, into routine care and specialist healthcare clinics in England, as well as to allow the company to develop a larger multi-pathogen point of care test. So in this presentation, I'm going to really focus on the first 2 points. So that's the clinical study and the qualitative social science study. And I'll be drawing from data from both of these to look at the process evaluation work. So what was the implementation process? It was a multi-center experimental model to support clinical adoption. And what we did was that we turned the traditional clinical adoption model on its head. So instead of the service actually purchasing the test ahead of time, what we did was that we gave the clinical service a chance to be able to play with the machine, as it were, before they adopted the test into routine care. And we did this by having discussions with service stakeholders, which led to workshops where stakeholders from all parts of the service, from the commissioners right down to the clinical care and support staff, discussed the test itself and its suitableness for their local settings. And then those led to informal implementation meetings, specifically among the clinical care group, to be able to discuss the clinical pathways in which the test would be implemented. We then allowed the clinics to have a clinical validation phase, which meant that the test, the new point of care test, would be compared directly head to head with the laboratory test that was being used in their clinical service. And the research team helped with the evaluation of those results. If the care team felt that these results were acceptable, then we would go on to routine use of the test, which meant that the service would provide the results of the test to patients in their clinical service routinely. Those also would be evaluated by the research team and would input into a case for formal clinical adoption. So unpacking some of our causal assumptions, we had development of our theory of how change worked and would work within this intervention by a review of the literature, which was first done informally, and then later a systematic review and development of a value proposition for a chlamydia gonorrhea point of care test. Then also our previous empirical work with patients and clinicians, and a theoretical understanding of how to create sustainable change was used as well. So unpacking that further, we found in our systematic review in specific that values were largely setting specific, and that less than ideal tests really had a place in the betterment of clinical service delivery from both clinician and patient perspectives. And that's important to understand because, as many of you who are dialing in may know, that 30 minutes, although that's a fast test, the normal clinical patient visit is about 15 minutes. So these tests are still less than ideal in many different ways. Our previous empirical work with clinicians and patients showed that there were structural factors as well as social and contextual factors that were at play in understanding how and when and how and when to adopt a chlamydia gonorrhea test. And that was both around the design and function of the test, accuracy, cost effectiveness, and fitness for purpose within the clinical patient population. So, for example, validation for extragenital sites, which is particularly important for communities of patients with large populations of men who have sex with men, and whether or not this would be a replacement or companion technology. The structure of the clinic was also highly important, such as the amount of bathrooms and areas where patients could take samples, and structural and contextual factors such as local epidemiology of emerging infections, as well as the potential patient acceptability of new pathways for these tests. I also based the model on the seed scale approach, which is a model of international community development, which has been used since about the 1970s, mainly in low and middle income countries to collaboratively design and implement interventions. And that's really premised on three-way partnerships between communities, officials, and experts, showing that if you bring together bring together locally specific data and action that, so have empirical evidence with tacit knowledge that allows for actions that create sustainable changes in behavior. So bringing that all together, we felt that first, that the trust in the point of care test would increase as a result of participating in the validation first design pathway. So being able to see hands-on in their own service, using their local data, that the test performed really well in terms of accuracy, would increase trust in test results among the clinical staff, so they'd want to use it more, and increase trust and value for money among managers and commissioners, which was part of the health economic study. We also thought that cooperation and collaboration between these multiple levels of stakeholders would lead to implementation successes, such as first, the early attrition of services where the point of care test was not fit for purpose would be achieved via the stepwise workshop model. So not wasting a lot of people's time and energy implementing a test that would ultimately be abandoned. um, that agreement of quote unquote good clinical pathways that worked within the service would be achieved and would also need minimal change during implementation via this collaborative method. And that collaboration between different levels of the clinical care team was necessary for changes to support changes in service delivery. Collaboration with the external team would enable data collection and analysis by the research team would also lead to greater success and application for the test's adoption into routine care after the end of the study. And I'll look at each of these in turn and whether or not they worked or we were correct in our causal assumptions. So first, to be able to understand the potential feasibility, the request, so we participated in informal discussions with 14 different services. Five of those withdrew from the program prior to the workshop because they felt they weren't actually interested in adopting the point of care test. So once we told them that this wasn't really a research program, this was more of an implementation program, five of them weren't interested any longer. And one of them requested to defer to a waiting list, and that was because the potential site leader did not have sufficient contacts to organize a workshop. So, in specific, he didn't have the contacts with the commissioning team and the managing team that would be in charge ultimately of the decision to purchase the test. So 8 participated in a clinical planning workshop, and 5 of those withdrew after the planning workshop. So that's a pretty high attrition rate, so 62.5%. And that was around stakeholders felt that it wasn't really a good fit between the test and the local clinic population, and also due to administrative and planning difficulties with the research study and the implementation aspects of the project. So all in all, 3 completed the clinical study. So again, we were wondering whether or not this model would lead to early attrition of services, and where the test wasn't fit for purpose. And it's likely that that was the case because, again, we did see those high levels of attrition. So when we look at the point of care test implementation delivery by service, we can get clues into the fidelity and the dose of the intervention. Here you can see our three services. They all were specialist sexual health services, but they had different number of participating clinics. And really importantly, if you look at the columns on clinical validation days and routine use of test days, you can see that service one actually did not adhere to our intervention model, choosing instead to implement the test as a routine use throughout the period. And that was partly due to logistical reasons because the end date of when we had to stop implementing the test in the study was fixed, and they didn't come on until a little bit later in the program with their implementation plans. It took them a little bit longer to get those clinical pathways right in discussions before implementing the test. They also had different clinical pathways, not massively different, but what could be possibly expected from having quite different clinical populations. So when we look at the accuracy of the test, so I'm reporting here the positive prevalence agreement, negative prevalence agreement, because this was not a formal diagnostic evaluation study, and should not be really looked at in that way. We did find really high levels of agreement between the test of the routine test, so that lab test, and the new point of care test. And this is for chlamydia. And we see even higher agreements among the gonorrhea results. We also had similar low numbers of invalid results between male and female patients across the study, and there was no obvious association between symptom status or sex, and no obvious association between the differences in the ways that the point of care tests were implemented. So there was pretty much a blanket results across the three clinical sites, despite their differences in implementation. And what that showed was that was a really actually pretty accurate and good test. But although we thought that the trust would increase as a result of participating in this pathway, this validation first pathway, it's unlikely that that actually made any difference. And despite this high level of concordance between the lab tests and the new test, there was these small differences that they saw really resulted in concerns for some staff, especially healthcare assistants who were the ones that were delivering the results face to face with the patients. So, quote here says, "Do we trust the brand new machine that we've got, or do we trust the one we've been using for a long time?" So that's tricky, but the way I rationalized it in the end was that you're going to get false positives either way. When we send off our swabs anyway now, we can't fully trust that they're going to be correct. So that was sort of a rationalization for continuing use of the test, but we were really still concerned, like, why didn't this work? What was the issue here? Um, and some of the reasons why were seen in, again, our qualitative data. And what we found is that this might actually be the case for any point of care test. So a quote here from one of our nurses said, "I want this to be the correct result for the patient who is sitting in front of me." Whereas if you're giving them a result over the phone or by text, so the normal way of being able to um, share the results with the patient was that you would send a text message or have a phone call with the patient, because that test result would be delayed by a number of days. And here you can see in the time taken from sample to patient results in our quantitative data is that the time from sample to patient results was drastically reduced. And in most cases, this was used as a same-day test result. So again, there was a big difference in the way that the results were delivered. So the importance of being able to give a correct result to a patient that's sitting in front of them was felt a lot more keenly than delivering the results remotely. Right. So what we also theorized was that collaboration would enable agreement of good clinical pathways, which would need minimal change during implementation. We found that this was likely to be the case. So qualitative descriptions of clinical pathways, both before and after implementation, showed that minimal changes were being made to the clinical pathways. So that could have been due to the short durations of our implementation. Remember that that varied from 12 days to 33 days, but we didn't find any difference between the clinical services in our qualitative data. We also thought that the collaboration between different levels of the clinical care team would be necessary for changes in service delivery. And we found that that was likely. So, although the interviews revealed that service leads were responsible for driving changes, the majority of our respondents cited the importance of including all levels of staff in both the delivery and evaluation of the point of care test. So, our quote here from one of our nurses says, I think when it comes to evaluation, everyone is involved. It might not be coming together all at once. It might be various teams getting feedback from various people. But when it comes to evaluation, everyone's input is valuable. So when it came to collaboration with the external research team, and whether or not that this data gathering and analysis would lead to greater success in applications for adoption. Unfortunately, that's unknown. So, although the work was planned to be to continue to study post-program plans for adoption, the point of care test wasn't actually placed on the market for purchase when the study ended. We do know that all of the clinics said that they would like to adopt it, but whether or not that would have happened in practice is still unknown. So, in sum, this gave us a signal that the critical aspects of our theory of change, which is really around the framework for understanding community change, is likely to work. And we're developing a more defined implementation and evaluation program across different settings and different STI point of care tests. So, revising the program for implementation to be piloted in one or two high income countries and two low and middle income countries, and this will be evaluated based on realist evaluation methods, which should more clearly define mechanisms of impact and our expected outcomes. So go beyond a signal into something more definitive. So with that, I think I'm going to stop sharing.
Okay, thanks. So hi everyone, my name is Abdul and I'm a second year DPhil student with Mike and the team at HSC. So what I'll be doing today is, so Sebastian has given you an overview of what process evaluations are, and then he's also given you a larger project that did the process evaluation. So what I will be doing is focusing more on intervention fidelity using my DPhil as an example. So I want you all to consider a drug. So let's say this hypothetical drug is drug X, and maybe in a journal article, what was said is drug X cures HIV, for example. And then the drug was used in a 3-arm trial. So ideally, as a researcher, if you were to read this paper, if you were to consider from the patient side, you want the arms to be equivalent from the patient side. So what I want you to pop in the chat is, if you were to think about this from a drug perspective, what do you want to know about the three different groups to interpret the trial? So considering this from a drug perspective, what would you like to know about the drug? Yeah, so I'll just be looking at the charts to see what people are saying. So a 3-arm trial, drug X was administered to 3 groups. What would you want to know about drug X if you are reading a paper on drug X and HIV? Okay, so groups are similar in type of person, yes. But what about the drugs? So let's leave the people. What would you want to know about from a drug end? What about the drug? Okay, so mechanism of, okay, fine. So we have one length of use. Yes. Yes, dosages. Was the dosage different? Was the strength of the drug different? Okay. What else about the drug? So think about it from we have 2 ends. Ideally, you want the patient group to be similar, but what would you like the researchers to provide you from a drug end um, that will show how? So, for example, someone has mentioned here, how do the dosages across the true 3 groups differ? Okay. Yeah, efficacy. Okay. 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 So I guess what we're trying to get at is if you were to read this paper, we've mentioned some of this. You want to see across the 3 groups, does the dose that was given differ? Does the frequency differ? Does the duration differ? At times, does the route of administration differ? Or did one group, for example, get a placebo? Did the other group get standard therapy? So if you put this in mind for an RCT or a trial, let's apply this to complex interventions. There's starting to be a movement in reporting and reporting complex interventions, and this is related to describing our interventions to enhance replication. Now, this is the TDIA checklist, and the TDIA is an expansion of items on the consultant's spirit statements, and it's a way of thinking about our interventions like drug X I showed you previously. So rather than say this was the intervention, people are starting to ask for proper reporting. You delivered an intervention. What was the dose or intensity? How did you deliver the intervention? What processes did you follow? And if you think about an intervention like drug X, all this can actually influence how efficacious or how we can replicate an intervention. So that's where partly intervention fidelity comes in. It focuses on dose or intensity. So intervention fidelity is actually the extent to which an intervention was delivered as it was designed or written to be delivered. So in one sense, in simple sense, it's how um, the it's how your research centers, for example, uptake your intervention and essentially what is the effective dose you are delivering. So the scope of this presentation will be to show you an example of a process of conceptualizing and investigating intervention fidelity using my DPhil as an example. So for a bit of background, Sebastian showed you this slide, and what you have in this slide is the MRC framework, and you can see from the presentation he had, the research he presented touched on a number of places here. But what I'm going to present today touches on this point. So regarding the implementation, what is delivered, what's the fidelity, and what is the dose? So my presentation will show you how I've thought about this in my DPhil and what we're starting to find. To create context, what I want to show you here is my research is in Kenya. This picture is from Malawi, but generally Kenya and Malawi share similar challenges related to this. I also have experience practicing in Nigeria and as a clinician, and we had similar experiences to this. What you see in this picture, if you're not familiar with a lot of context like this, is that The two people you see in the center there are nurses on a medication round in a pediatric ward, and you can appreciate how busy the pediatric ward is with few nurses. So if you keep this picture in mind, my DPhil is nested within a project called HiQ. A lot of us on the call will be familiar with HiQ, but if you're not familiar with HiQ, one of the things HiQ is doing is we prospectively increased the number of nurses in select newborn units in Kenya. So increase the number of nurses in the context you saw previously, similar context you saw previously. And my DPhil is just saying, what is the effect of this on care quality? If you think about my research thinking in simple terms, it's we are adding nurses to hospitals and we're trying to see, does this process improve quality of care change? And we're using a before and after design with some controls. So before we added nurses and then after, and then we'll assess after. So baseline evaluation and then an after evaluation. But as Sebastian mentioned, there's that black box, and traditional research will tell you intervention outcome, eh, but not unpacking that black box. So, as a secondary objective, one of my secondary objectives is to look at how does differential uptake of our intervention, how does this affect quality of care? So it's a way of explaining why the intervention will work or might not work. What I'll do in the next slide is show you a bit of the thinking before we move to fidelity. Central to my DPhil is a structured checklist tool where we have people who call observers by the bedside use a tool to take data on care delivered to a baby. So babies in the newborn units might be fed, will have cord care, will have some medication. So the structured checklist is used to take data on, was this done, was this not done, and then when was it done? And then in the end, the main measure of quality of care is to create an aggregate score for each baby, which is observed care divided by the expected care. And but part of what we can do with this tool is to say by the bedside how many nurses turned up for the day, and then also to assess the patient numbers for the day. So this is the thinking. What I'll show you now is, remember Sebastian spoke about a theory of change to inform your process evaluations while you go along. What I'll show you is a logic model on the next slide. Now, this is a logic model. But you don't have to bother about the details. I'll break it down in subsequent slides. But if a logic model is a hypothesized description of a chain of causes and effects that lead to an outcome of interest. So I know Ben is on the call, and I know Sebastian spoke about theory of change. And a common question is, how does a logic model differ from a theory of change? So in a logic model, there's no emphasis on the mechanism. So for example, stage A leads to B. In a theory of change, there will be that explanation of what are the possible mechanisms that lead A to B. But a logic model is there are no mechanisms. A second difference is a logic model is linear, so you're going from left to right. But in a theory of change, an effect might actually affect the cause, and so you might have loops. So what I want to do is focus you on different aspects of my logic model. I'll start with that aspect. So this is the logic model. The logic model for the DPhil was built on a framework referred to as the Donabedian framework. So what Donabedian proposed is, when you think of quality of care research in healthcare, structures within the system affect processes that happen, and then this ultimately affects outcomes. So the logic model was built using the Donabedian system. So if you move from left to right, the intervention we had was we're introducing supplemental nurses to neonatal units. But part of what we're affecting is the structure, where the nurses we add ideally should integrate successfully into the neonatal units. And then what I have in blue are things I can measure from my DPhil, for example. And then this affects processes, for example, increasing nursing care that is delivered to patients. And then that's how the logic model looks. So there are different parts to it. The first part you see there, the integration, so just to mention, this is um, this is my logic model, but the parents project itself, it has a theory of change it's working on, but it also has a qualitative process evaluation where the process evaluation is also evaluating the integration of these nurses into the units. But for my DPhil side is the intervention fidelity measures. And this comes from earlier work on an umbrella review we did early on in the DPhil, where part of what we looked at was how is staffing measured within research? And we picked three of these indices, which is the total nursing hours per week, and the other two you see there. And I'll explain this in slides down the line. What I'll do is try to show you other aspects of the logic model to prove a point later on. In this slide, what you see are the assumptions at each part of the logic model. I want you to focus on assumption B. Assumption B states that if we do add nurses, our added human resources will not be diverted. So that's an assumption because you can add nurses to a system and then nurses are transferred, pulled out. So we recognize that assumption early on in the research. And then what we did was has an intervention to address this key assumption. We developed a memorandum of understanding and we signed this with the county government and then with the hospitals to say the resources will not uh, be diverted. And then we decided we're going to track intervention fidelity. So in the next set of slides, I want to show you the fidelity variables and then try to explain this to you. So we had 4 hospitals. Within the 4 hospitals, there were different shift types. So for example, if you look at H1, there were 2 nursing shifts. There was an evening shift and then a night shift. So at the extreme are the duration of hours for those shifts. So if you think about it in a way that a nurse who did an evening shift on H1 will contribute 10 hours to care. And then you can see how that varies across hospitals. So what we had was a complex non-uniform shift type, and then where we had some overlapping shifts. If you look at H3, for example, you will realize that the nurses who come on afternoon shift overlap with those in the evening. So obviously a complex non-uniform overlap of shifts. So for the fidelity variables, we had 2 variables on unit level. The first is the total nursing hours. So the total nursing hours will say if, for example, one nurse turned up on evening shift in H1, she contributes 10 hours to nursing care. A second nurse might turn up at night. She contributes 14 hours to nursing care. So it's summing the total hours contributed by nurses um, for care. And then the nursing hour per patient day takes that total sum. And then if we were considering that value in a month, will be let's divide it by the patient numbers in the month. And it's a way of recognizing that patients will fluctuate. Patient numbers will fluctuate irrespective of the total nursing hours put in. But the third variable is a shift level variable. If you remember, I showed you the NCI tool, and I said what we could do with the observation tool was using the observation tool, we were able to tell how many nurses came on a shift, how many patients are present on a shift. So using similar methods, we sum up the number of nurses across a 12-hour shift. So nurses might present evening, afternoon, divided by the patient numbers on that shift. So I want to show you how this works in practice. For the unit level, what you see there is a paper rota for one of the units, let's say unit X. So paper rotas are generally used within the system, and it's central to the way work is planned in the system. Um, so if, for example, we were to look at Tuesday, E means evening, N night. The red color, NO means night off. So you can tell the number of nurses who were present on an evening duty, a night duty. The numbers you see there are nurses who are on leave. So you can actually tell that also. So we're able to sum up total nursing hours over a period, and then um, Mike's network has data on the number of patients per month in different hospitals. So we're able to derive the second unit metric, which is the nursing hour per patient day. And then, as I mentioned earlier, we're also able to use our structured checklist, which is during observations, to determine on shifts where we're observing babies, how many nurses are present and how many patients were present. I want to show you some preliminary results in the next set of slides. So what we have here is the first set of results. Remember, I mentioned the nursing hour per shift variable, which was derived by getting the number of nurses on a shift and then getting the number of patients on a shift and then dividing the hours um, given by those nurses within a 12-hour shift divided by the patients. So what you see here is our horizontal box plots. So on the y-axis are the 4 different hospitals, and then on the x-axis is the value. If you're not conversant with box plots, what you need to be focusing on is that line in the middle, which gives you the median nursing hour per patient shift. And then for those who want more, you can focus on the length of the box, which tells you this is the variation in this metric across shifts we examined. Um, I've presented this earlier to some of us on the call, but just to highlight, if we were to translate this into average time provided by nurses on a 12-hour shift per patient, what we have here is H1 is 24 minutes, and then H3 is 40 minutes. Not to consider the absolute value, I want us to start trying to interpret this in a fidelity sense. At baseline in H1, it was 24 minutes on average per patient for a 12-hour shift. If our intervention works the way we think it will work, if we're assessing this in the post-intervention, then that number should go up. In fact, a prerequisite for us to say, if we see a change in quality of care, for example, a prerequisite for us to ascribe that to our intervention is to say, for example, the median post-intervention nursing hour per patient shift is greater than significantly than the pre-intervention. So the fidelity objective for this variable will be to describe how the magnitude of change affects how quality of care will change across hospitals. So just to explain this is, in H1, this was 24 minutes on average. If we're able to move it to 36 minutes in the post-intervention, that's a 50% change in the baseline value. If in H3, we're able to move it from 40 to 50, that's a 25% change in the baseline value. So what intervention fidelity will do here is say those in H1 obviously was higher, and then we'll see how that magnitude affects the quality of change. So this is at the shift level. In the next slide, what I want to do is show you how I've started to work on the unit level variables. This is still work in progress. For the unit level variables, so this is, will I say a line graph, let's say. This is a line graph. It hasn't been smoothened, so it's quite primordial. So this is in hospital 1. What you have on the y-axis are the number of nurses available on a rota. And the way this was derived is to say, if you saw the earlier rota where you have nurses on a rota, this is those nurses on the rota, and then subtracting the nurses that were on maybe annual leave, sick leave, or any form of leave, and then getting the number of nurses that were available on each day for work. So that's the y-axis. The x-axis is the number of days has a continuum. So day one, what we did was we tracked back rotas from September of 2021. Day one represents September 2021, and day 330 August 2022. So rotas over a year. So what I want to show you is how it looks. So we intervened at this period. This is hospital one. You can appreciate there was a step change in the nurses available. But then, okay, and this was when we took our baseline data, because if you remember, we took baseline data, intervened, and then we plan to take the post-intervention data this month, yeah. So this was when we took baseline data. But what we noticed for this hospital is after a while, it seems there was a sustained increase, but then we're seeing a tapering off of the nurses available for duty. And then we said, why is this happening? We decided, let's look at the nurses who go on leave. So what you have on the y-axis here are the number of nurses who go on annual leave, sick leave, or some form of leave. This is where we intervened. If you appreciate, following intervention, there was a rise in the number of nurses who proceeded on leave. If you remember, what I showed you earlier on was our logic model. And at the start, part of our assumptions were we're adding nurses. What if for some reason the existing nurses get taken out of the system? So we thought about the assumption, which tells you why logic models on theory of change, is it changes now? Theory of change are important. So we thought of that assumption. We instituted mechanisms to try to address it, the memorandum of understanding, but it just goes to show you how difficult it is at times to conduct complex health intervention research, because things don't really go as planned. In one sense, if you were in the learning event for some of us, there was this concept of dark logic where you intervene and then you have unintended consequences from your intervention. So in one sense, this is an example of dark logic. So this is hospital one. I'll show you hospital two and then hospital three. I don't have data on four. This is hospital two. On the y-axis is the number of available nurses on the rota and then the continuum of days. We intervened at this point and we took our baseline data at this point. I hope you can start to appreciate hospital two is what you probably describe as a quote unquote good adopter of the intervention. You can appreciate there's a sustained step level change in hospital two. So what we're starting to see is even without using the metrics, this is just number of nurses, we're starting to see that differential adoption between different hospitals related to our intervention. And then this is hospital three at the point we intervened, baseline. And then you can see what happens after. So next steps for this fidelity exercise will be to derive the actual nurse staffing metrics. So total number of hours and then the nursing hour per patient day. Because in essence, we are able currently to tell the number of nurses and how that changes. But different hospitals will use nurses in different ways. A night shift, for example, a nurse used on the night shift contributes 13 hours to patient care as opposed to a nurse on an afternoon shift, which is 6 hours. But ultimately, the idea for this process evaluation will be to examine how differential uptake of this staffing intervention measured by this staffing metrics explains any observed differences we see in changing the quality of care. So I guess in summary, what I've done here is feed into what Sebastian spoke about, a bigger process evaluation, but here give you a brief overview from an intervention fidelity angle, and then show you an example of the process of thinking through and then investigating how intervention fidelity might change and might actually affect your outcome.